Welcome, everyone. It's my pleasure today to introduce to you Professor Sudip Gupta. Professor Gupta is a faculty at the Carey Business School at Johns Hopkins University. His current research and teaching interests are in areas of artificial intelligence, machine learning, and fintech, specifically in the areas of algorithmic bias, alternative credit rating, credit derivatives, and treasury auctions. In addition, he's also a core faculty at the Hopkins Business of Health Initiative, Center for Digital Health and AI at the Carey Business School, and also a fellow at the Center for Responsible AI at the Indian Institute of Technology in Madras. Also at Hopkins, he is also a consultant for multinational financial corporations, government committees, and serve as experts in legal cases involving antitrust and financial issues. So without further ado, I'd like to give the stage over to Professor Gupta.
Thank you. Thank you, Alvin. Let me try to share my screen and let me first make sure it's visible. Can you see my screen? Perfect. Thank you, Alvin. Thank you, Brittany. Thank you for the introduction, as well as inviting me to talk about some of my current work that I'm working on. And Brittany, you are going to monitor the chatbot, right? I'm not
Yes, I will take a look at the chat throughout the talk.
Sure, thank you. So as Alvin mentioned, I'm a faculty professor at the Johns Hopkins Carey Business School. So I have a background in finance and economics. I was trained in the Indian Statistical Institute and Wisconsin-Madison in both economics, computer science, and statistics. And then, so I've been working mostly in those areas, but at the same point of time, through my other associations, I've been very intrigued and interested in working and writing papers in healthcare, and that I've been doing for quite some time with friends as well as my colleagues. And coming to Hopkins kind of increased that passion. And of course, in this age of AI, we cannot get away without talking about the machine learning and AI algorithms. So I mostly work on the predictive part of the algorithm, but also quite a few of those papers of mine in both finance and healthcare are on that line. But I've been working very vigorously in the area of debiasing and responsible AI of late. And today my idea is to share some of my work in that area with some live healthcare data. I'll first talk about some of the challenges, and then we'll get right into the talk. The way I see myself today is more in terms of learning, because I do want to, I'm going to give something relatively novel, and do want to talk more about the implications of those, as well as I want to get your comments. So please feel free to stop me during the talk, as well as after the question and answer if you have any questions. And I feel privileged to get your comments on my current work. So on that note, no talk these days on AI cannot start without ChatGPT. So I'll start with this, that I went to ChatGPT first, just to, when I was preparing the slide. I have some definitions of algorithmic bias in mind, but let's ask ChatGPT on what does it mean by algorithmic bias. And this is what it gives me, that it refers to a systematic and unfair discrimination or prejudice that can be embedded in the design, development, or deployment of algorithms. It's relatively vast in terms of its way encompassing different stages of the algorithm development. These biases can lead to discriminatory outcomes on unfair treatment of certain individuals or groups based on characteristics such as race, gender, age, socioeconomic status, or other protected attributes. And then it started to talk about the sources this biases could come from, and then how we could potentially address this. So I'm going to talk in more detail of this, but after looking at this, then I put in the next question, which is, can we define algorithmic fairness? And then it kind of gives me a much more detailed and important definitions of what the fairness comes up. And it's interesting that it refers to the concept of ensuring that algorithms and their outcomes are fair, unbiased, and do not perpetuate and amplify existing social inequalities or discrimination. And then it kind of lists out there are several key principles and approaches to achieving algorithmic fairness. It talks about the definition of fairness. So of course, we have to be very careful on how we define the algorithmic bias and fairness. Then it talks about that, does the algorithm actually already know about the notion of the fairness or not? So that creates an important part. It talks about the fairness evaluation. It talks about how you could intervene. And then, of course, at the end of the day, it talks about the transparency and accountability. I'm not going to get into each of the detail. We'll be right now, we'll be talking in more detail with examples later in the talk. But later, this last statement is quite interesting, that overall, algorithmic fairness is a multidimensional and evolving field that requires interdisciplinary efforts from computer scientists, ethicists, policymakers, and stakeholders to develop and implement fair algorithms that promote social justice and equality. Now this is like encompassing everything. And this is also highlights the importance of how complex this issue is. And we have no idea probably right now, or do not have too much of an idea about how and where the problem could come from and what are the possible solutions of these problems could be. But also it highlights the nature of interdisciplinariness. And this is where I thank you for having me, as well as looking forward to your comments, where I would like to know and learn more from you, as well as share my examples from some other fields, as well as from using various healthcare data that I've been working with. So with keeping this in the background, so we are kind of dealing with something which is everybody understands this has huge importance, but at the same point of time, given the cumulative knowledge of ChatGPT, it kind of is not clear exactly how we should actually proceed in defining as well as treating algorithmic bias and proposing and promoting algorithmic fairness. So in that venture, let's start with what I want to talk about, which is going to be one of those approach. So I'm going to talk a little bit about the motivation and background, and we'll talk about quite a few examples in healthcare and various debiasing techniques that has been used or proposed. And then I'm going to talk about the problems with many of these measures as well as techniques. And then I'm going to talk about one approach, which is causal graph-based approach, and why we need that to mitigate some of the problems or challenges that comes up, which I'm going to delineate during my talk. And then, of course, this is not a panacea. So we'll see that there are challenges even that approach too, and how we can move forward. And I'm going to talk about, when I'm going to talk about the causal graph approach, I'm going to give examples and my analysis using the causal graph on a public database called Mimic database, which many of you may already know about, which has information about some numerical information about various patients. It has images, X-ray images of various patients, as well as the doctor's note. I probably will not be able to go beyond the numerical data-based information. I'll try to talk a little bit on the image data, and I'm sure won't have time to talk about textual data, but there are lots of interesting multiple projects that I've been working on, and not only just using this database on these 3 dimensions, but with other databases too. So I chose Mimic database because there's a public database, and we can all relate to what is going on in that database. And many of you may already be familiar with that. So without further ado, let's get started with some of the examples, motivation and background. And this is an article of late that under diagnosis bias of artificial intelligence algorithms applied to chest radiographs in underserved patient population. This uses the Mimic3 database, recently came up in Nature. And it says that the AI algorithms would inaccurately label an individual with a disease as healthy, potentially delaying access to care. So this is serious. The classifiers, which is in machine learning terminology, it says the probability that you want to classify someone as having a disease versus not having a disease based on the particular chest X-ray or particular types of X-ray. It uses state-of-the-art computer vision techniques consistently and selectively underdiagnosed, underserved patient populations, and that the underdiagnosis rate was higher for intersectional underserved subpopulation. So this is again serious. And again, if you try to look at how we actually measured that, and this is where the ChatGPT definition and compositions comes in mind, that there is so much different complexity on how you measure. One of the way you can measure this, the underdiagnosis rate, is say the probability that the AI algorithm incorrectly assigns someone as having no underlying condition, which is the false positive rate, versus any particular type of disease that the X-ray was actually going for. And it turned out that the female Black patients, Hispanic and young patients, have much higher false positive rate. So this is where those numbers are. So you can see that the female has relatively, and this, again, I'm quoting from this article, and this is, the dotted ones is the significant difference from the other group. So the female has much higher false positive rate, means they're not going to be diagnosed having that condition. The Black population is going to be much likely to be underdiagnosed related to the other populations, and similarly for the younger population as well as for the Medicaid, right? So this is again one way of measuring, but it kind of highlights immediately that, well, if I have an algorithm, which if I'm using an AI algorithm, and now these are very rampant of using various devices to use the chest X-ray radiological images, and trying to find out whether a particular patient is has some underlying conditions or not, I'm going to underdiagnose a particular specific group related to the other group. And this is important and crucial given that we have increasing number of algorithms. So this is just one example I gave you. There are lots of algorithms which is receiving approvals from the US DA, FDA. I think that right now it's 500 plus AI-based software as a medical device, which is out there. There is not enough concrete regulations yet. We do have the President Biden's recent executive order, but there are lots of things and sub-pieces to be taken together. And it kind of says that, well, so I'm quoting these two from the US Food and Drug Administration. So they have a discussion paper, which says that what should be the proposed regulatory framework. And if you see this is again coming from there, they kind of talk about that there should be an area of collaboration, and the focus should be, we have to have a collaboration across different public health group. We need to have advance the development of regulatory approaches that support innovation and support research, of course, using the evaluation and monitoring of AI performances, and promote the development of harmonized standards guidelines, which means if you want to flip this up and try to think about what is currently going on, there is virtually nothing out there. So we really have to start everything from the scratch. And including, and that scratch start includes the fact that we sometimes may not actually be defining the bias or fairness accurately or appropriately, depending on the population and the problem at hand. So this is where we are starting from, right? So and again, I keep the definition of ChatGPT is in the background. Now it kind of highlights the complexity of the nature. Now let's try to look at some of the origin of these biases that could potentially come from. Now, so for example, these are some of the references I've given, and I'm quoting some of the information from there. The current AI algorithms for the diagnosis of skin cancer using a particular type of photographs may be developed on data sets that underrepresent darker skin types, which may exacerbate the health disparities of some geographic regions. Now, if you think, I'm not going to get into how does machine learning work, but we generally have a set of data sets, which are training data sets. We have a set of data sets that we use our model to train the model, and then we use a testing and validation data set to actually see the performance of that algorithm. Now, if the underlying training data set is coming from one group or subgroup of the population, it may be possible that if we are testing or actually taking the algorithm, implementing it in a particular different subgroup, it might end up underdiagnosing. So for example, skin cancer, just to give an example which is related to this, that most of the training data sets of the skin cancer is based on fairer skin people. And where the detection, if we use those algorithms to figure out what is the probability that given a certain pigmentation of your skin, you have a skin cancer or not. If you are trying to predict that using an algorithm, which is machine learning based, then that is going to give you some certain kind of thresholds of diagnosis for a skin cancer. Now, if the same algorithm is applied to someone with a darker skin, it is possible that those threshold that you have actually defined or based on the training data on a fairer skin is going to underdiagnose the skin cancer type in the darker skin population. Now this is serious. Again, this goes back to our previous article that we talked about, that a certain group are going to be disadvantaged and biased outcome and algorithms coming because the training data is starting to be biased. So that is one potential problem of where the bias could potentially come from, that the training data, underlying training data is going to be biased. We may want to define, again, there are various ways to defining the bias. We may want to define how you want to actually make sure that there is once we have detected some kind of a bias, how do we actually define it to be fair or debias the algorithm if we want to come over there. And one of the ways that if we see the probability, so this is the probability of detections, y hat equals 1, for example, the skin cancer, given that you are a particular race or gender, A, that probability has to be the same given another race or gender, B. So if that is the case, then that's the demographic parity definition. But the moment you see that there are multiple definitions comes here, one is predictive parity, one is equalized odd, you kind of get the idea that, well, none of the definitions are actually going to be foolproof definitions, because if we use one definitions versus the other definitions, we may actually overestimate or underestimate the bias. And hence, if we are going to debias, we may actually end up over correcting or undercorrecting, which is going to lead to another set of problems to begin with. I'll come back to this later in terms of actual definition and how should we work about this. So now you get the idea that there is a problem coming from the training data. That is one of the source of the bias. There's a problem that might come from the way you actually measure the bias. So one of the way you actually would like to debias, for example, many of the popular debiasing techniques is said that, well, if a training data is underserved, why don't I resample? And you see in this graph, there is two sections where this is the original data sets where this is again about tumors, and you can see that the large tumors are underrepresented here. And you can see that this is probably the threshold based on which you define whether somebody has a tumor which is cancerous or not. And then you actually resample this test training distribution in such a way that you have more, you oversample more tumors which has larger in size, and then define a new threshold. And you can see that these two thresholds look very different. This dotted lines are the thresholds. Now, that is one way of importance weighting. Now, how do we decide which way we want to, how much importance should we give, or how much oversampling we should do, how much undersampling we should do? Again, that's a question that nobody knows, but you got the idea that the moment we do this oversampling or undersampling, it's creating or adding another set of problems that we might end up doing something ad hoc, which may actually increase to some extent some of the biases. So there are various criteria, of course, you can try to minimize, but this is another potential problem. Another bias mitigation technique has been proposed to be called fairness through unawareness. That, well, if you're using a training data, always take out any kind of sensitive attributes from that when you're fitting a model, right? So for example, if you have race and gender information, take those markers out, and then you train the data, train the model on the data, and then see what the prediction actually does. And it has some history. So in the 1971 case, the Supreme Court, in a different, not healthcare, but it prohibited the use of race in hiring decisions, even if discrimination was not intended. So for certain cases, you are actually not allowed to include race or gender. But then you start, and let me give you another example of that in the Compass algorithm case in 1998, that it actually said that if you exclude race, then you actually ended up doing better to some extent. However, again, this is the problem of, or the nature of the problem, that if the race, gender, or any other sensitive attribute, if that is highly correlated with some other variables, as well as has high predictive power in predicting the ultimate outcome, we may actually do more harm by not including that. And how we define harm is a point that I'm going to talk a little bit later. But there are evidence that if we have race, then you might actually do something better versus if you do not have race in those type of predictions of debiasing techniques. So now you see the problem that there's a problem with the data. There's a problem the way we define bias, that there's a potential problem with the way we are actually going to debias. And each of these cases could potentially increase or decrease the bias reduction process. And of course, in this age, especially when it comes to healthcare, trust is an important factor amongst the patient population, and especially the group which is racially or for other sensitive attributes are relatively underserved for healthcare. If we have an algorithmic implementation of healthcare, which actually increases that bias and hence decreases potentially that trust, we are actually going to do more harm, because at the end of the day, if less people are participating in this kind of endeavor where algorithms and the techniques are important to move forward, where we need more different types of data from different kinds of population, because that's what's going to increase the chance of debiasing techniques if we have different heterogeneity group of populations. But if the trust gets reduced, especially in the earlier stages of when AI and healthcare is kind of taking off, we might actually reduce that, we might actually exacerbate the problem and reduce the chance of having more trust-based access to healthcare coming in. Another important challenge in all this, not that we didn't have enough problem, I keep on talking the problem, it's almost 20 minutes, so I'll move up a little bit more. Which is related to confounding. So we have this database, and let me first tell you the example, and then I'll articulate the problem in a different way. That we have this cancer and genome atlas database, and which has over 3,000 patients and 6 cancer subtypes, and it comes from various different sites. And the paper, I'm sure many of you are aware of this paper, kind of outlines the way they actually collect the data and the way that different sites are represented in that databases are probably very different and heterogeneous. It turns out that this histologic image difference between subatic sites can easily be identified with deep learning. So if you use a machine learning prediction technology to look at the data and say that, can you tell me where is this data coming from or from whom this data is coming from? It actually very highly accurate in predicting the site-specific signature leads to higher biased accuracy, as well as ethnicity can also be inferred from this type of databases. Now, if you now go back to this unawareness-based fairness, that you actually, if you're using the database, which somehow has the race and gender, you should actually remove this. But it already tells you that if you are using a highly advanced deep learning or AI algorithm, it automatically incorporates that information to some extent to tell you that where this particular data set is actually coming from. So this kind of creates some kind of a confounding and correlation that comes into the picture, which is more accentuated and could lead to some kind of a spurious causation, for example, that should we, if I go back to the question that should I use one of these sensitive feature in the AI algorithm decision problem, and it turns out that because of this spurious causation and correlation with some of the other variables in this data set, the overestimation in a particular case, this was the hidden in plain sight recent article by Darshali Bias, that you could actually overestimate that for a particular group, again, in this particular case, and reduce the specific referral, and hence reduce the access to healthcare, depending on the correlations between the two different groups of individuals in the particular database. If I add that, and many of you already know the Obermeyer paper, that at a given risk score, so there is an algorithm, this is not a machine learning algorithm, but it's an algorithm to begin with. The Black patients, if you use that algorithm, Black patients are considerably turned out diagnosed to be sicker than white patients, as evidenced by signs of uncontrolled illness. Now, if you start thinking about, well, I have designed an algorithm to figure out that whether you need the health care for a particular subgroup of populations, how come that particular algorithm is kind of biasing against the Black population? And it turns out that, of course, you cannot measure the actual level of healthcare or whether you are sick or not. You use a proxy. And in this particular case, the proxy was healthcare cost. And the idea is that, well, if you use healthcare cost, then of course, if you're sicker, you're going to have higher healthcare cost. However, there is an unobserved variable, which kind of creates the confounding that if you do not have enough access to healthcare, your cost is going to be lower to begin with. That does not mean that you are less sick, which means the unequal access, which is the unobserved confounding factor here, is going to underdiagnose the Black patients if they are somehow correlated with the healthcare cost of based on their income, for example. And hence, it is going to lead to this algorithm lead to high amount of racial biases. So on that note, in 30 minutes, I kind of summarize the problems, and I've talked about the problems a lot over here. I can talk a lot more examples, but to summarize, it's if the major problem could come from the training data is bias. It could be bias could also come because there is unfair decisions by against certain sensitive groups. But even if you do not have unfair decision or any intention to make any unfair decisions by the decision maker, because the training data is somehow over represented, that could create a problem. And then there is a nature of the black box of the AI algorithm. And if you have confounding and correlation, that accentuates the problem, right? So one of the way to take care of that is, of course, reprocess or reweight the training data. The question comes in how and why. So we then potentially probably have to design a pre-processing technique for each particular subpopulation, for each particular type of disease, if not anything more, consideration should be taken care of, which kind of creates, it's much more of a subjective way of looking at it. So now I'm going to, given the, for next 10 minutes at least, I'll talk about how the causal decision-making techniques, one of the causal decision-making techniques is by causal graph analysis, can actually reduce or address some of the problems that we're going to talk about. And I'm going to talk this through with an examples from the MIMIC database. And I'm going to, since you already know about the database, I'm going to go a little bit faster about the database, that it has numerical and image data. And it has data, for example, numerical data is outcome of interest is length of stay, hospital expiry. I'm actually going to talk about drugs per day used, and it has a very interesting both health as well as economic-based decision-making that might make that decision biased. We'll talk about a little bit that. The image data has diagnosed X-ray images for various different types of diseases. The sensitive attributes has age, gender, insurance, ethnicity, marital status. And I'm again going to talk about one particular case, which is drugs per day and insurance information, just to make the point. And of course, I have results and other information based on other outcomes too. Quickly, I have about 50,000, close to 46,000 observations from 2001 to 2012. And the observations has their information. The date of birth is kind of shifted randomly, but still in a consistent way. So I cannot identify the particular patient, but I at least know what's the age of that particular patient is, because date of birth and date of death is kind of shifted in a consistent way. I have the admissions data and other different types of data. And let's just talk about one example. And I'm going to describe my rest of the talk and causal graph analysis with that example first in mind. And then I can talk, if I have time, talk more in terms of other examples and other disease conditions too. So let's talk about the number of drugs prescription, as we talked about here. And let's see the insurance coverage that the individuals have. It turns out that if the individual has a private insurance coverage, the number of drugs prescribed, again, these are ICU patients, 14 per day, versus if they're not private insurance, they're 23 per day. So this is a statistically significant difference that for some reason, the private insured individuals are, relatively speaking, given less number of drugs versus other types of interest. And if I use this, ignoring any other causal or any other kind of confounding things, and to predict how many drugs are predicted per day, that's a regression analysis, I can see that if I use these type of variables as their control group or feature group, which affects individuals, like what type of diagnosis you had, your age, gender, insurance, race, language spoken, number of procedures, everything that is there in the database, I get a pretty high R-square in the trained dataset. But of course, the testing dataset is not that high, but still not a bad number, at least to begin with. The idea is not looking at these numbers, but understanding that there is a significant differences, as well as there are potentially other informations which probably affect these decisions of the drugs prescribed per day. And there could be some strategic element comes into here too, because you can think about people who have private insurance, they probably already have a work and the insurance provider is coming through their workplace. So somehow it is correlated with their income, and hence maybe it is somehow correlated with what kind of unobserved care they took about themselves to begin with, and so on and so forth. So you got the idea that there is potentially something else going on, which is not measured. And as you can see, the R-square is kind of not that high, partly because of that reason, and hence brings potential nature of the bias. But you see that the difference is really significant over there. I'm going to skip some of the basic bias detection techniques in the interest of time. I first used something which is available online for everybody, which is called FairML Health. If you go there and give your data set, if, for example, it kind of gives you some popular predictions on the definitions of fairness and whether you have some kind of a bias or not. So if I run it through that, and I'm going to skip this through, the shaded region, if something is shaded, means there is potential bias, and there are different metrics of fairness through which they actually measured this. And it turns out, yes, there is some kind of a bias in various different ways you want to measure the bias. So now, and I got similar results if I use the image data. So if I now try to figure out that, well, let's see how we can use a causal graph technique to make the problem that is kind of plaguing us. And I'm going to refer to Bloy and Pearl-based approach of causal graph. So let's spend a little bit of time on this to discuss about what the underlying problem is and how am I trying to solve that problem. So my problem is to predict my Y, which is, so think about if it is number of drugs per day, that's a continuous variable Y. If it is whether you have a particular type of a disease or not based on X-ray image, that's your Y. So either it's a continuous variable or 0, 1 information of whether you have a disease or not. Now, the graph technique kind of says that, well, whether you have a particular type of drugs or not might be affected by a bunch of variables called A. So A is a vector of variables. So here I talked about what kind of disease you already have, how many procedures you already took, and so on and so forth. So that's your A. It might also get affected by your gender or race or any sensitive attribute. For example, for a particular type of individuals, depending on what gender he or she is coming from, they may need more or less drug. So that's one of the sensitive attribute. It is also possible, so that sensitive attribute might actually affect how many drugs you need, as well as it is also possible that sensitive attribute also affects how many procedures or what kind of diagnosis you already had in the actual training data, right? So, and this in turn actually affects your overall outcome. So if you take these things, then we actually can use this relationship between S, A, and Y to predict. This is our plain vanilla machine learning process. Now, we know that this plain vanilla machine learning process has all those problems. Bias in the training data, there is a bias in potential way of defining how you are defining the bias. There is a potential way of, if you are doing to correct this, that's potentially going to be subjective. So instead of doing any pre-processing, how about I take the actual predictions and then I figure out that, well, let's figure out what is the strength of this arrow, what is the strength of this arrow, and can I estimate this function separately from this actual data? And if I can estimate this function separately from this data, I can then would be able to measure that what is the role of my gender, for example, on my number of drugs I should have versus how much of that is coming through the correlations over here. And that's not just it. In a more general case, you could also have some unobserved factor, as you talked about, confounding factor. For example, I may have a less access to healthcare. I may have other factors which might actually affect the way I'm getting diagnosed, and hence that might actually affect all those observed outcome. So if I can figure out somehow these arrows that I have over here and estimate this separately, keeping this causal graph in mind, then I would be able to potentially debias is the way I'm going to define, one way of defining debiasing, much better, because then I'm going to not do any massaging on the pre-processing of the data. I'm going to take the data and not do anything ad hoc. Once looking at the data, as long as I can figure out the underlying structural reason why one of the bias or the strength of the arrows are out there, I can then take this actual estimated value from a plain vanilla machine learning and change it depending on how I define the bias. So depending on the sensitive attribute, I might tune it up, tune it down. Just to give an example, think about the skin cancer. I know that color of my skin is going to, given that if I do not have a fairer skin, is going to make me biased against me being detected in the skin cancer technique. Now, if I can estimate that how much of this color of the skin part is going to contribute to the difference of underdiagnosis of my skin cancer, that once I have a prediction of skin cancer coming from a simple algorithm, I can put that predictive function and tune that. So think about that as a tuning parameter. And I can tune that to generate that, well, my threshold should be raised a little bit higher or lower, depending on my color of the skin. Why? Because that information is uncovered from that causal structure over here. I hope this is a little bit clear, but I'm going to, in the interest of time, in the next 5 minutes, I'm going to talk about 2 ways of defining that. One is the equal odds. The other is the affirmative action. And the reason I want to talk about equal odds and affirmative action is that everybody knows equal odds. It is quite common that the 2 different groups, so depending on whatever sensitive attribute you're coming from, they should have the same opportunity or same detection rate based on your machine learning algorithm. And that means I'm going to change my actual predictions to make sure that I generate an equal opportunity, or FEO, by tuning in such a way that I generate a new prediction, which kind of follows that fairness criteria. Another fairness criteria could be, and there could be multiple, I'm just giving you 2 for the sake of example today, that minority group may have lower access to healthcare, right? And hence more exposed to health risk. We just saw that from the Overmeyer paper. So can we make sure that, and because of that, training data may be overrepresented by one group, which again may lead to biased predictions for the health risk. Can I give more tuning for one group higher than the other group lower, which is the affirmative action-based approach? The reason is that since this group, say, and going back to the Overmeyer example, the Black population has an unobserved factor, which is access to healthcare, which lowers that. So given that I see a colored individual, and if I can figure out how much of that is lowered because of that color of the skin, I can retune to give them a higher probability relative to everything else for any other individual of a different skin color. And here are the ways to mathematically represent those. So the way you do it, you make sure that your sensitive attributes and the other attributes are same in distributions. If you change the sensitive attributes from black to white, or insurance to private to public, and whichever way you want to define, that's your equal opportunity. And your affirmative action is that, well, I know, depending on my sensitive attribute, I know my other attributes could be affected because of my sensitive attribute. So if I can estimate these functions out, if I change my S prime, means if I change my sensitive attribute of a different individual, can I figure out the same distribution for being treated or for being predicted of a particular type of a disease? And the way here is the actual way this algorithm actually works. I don't have enough time to talk about if I have particular questions, I'll get to the details of that. But let's talk a little bit about the results. If I use this structure, where again, the structure is that causal graph structure, where I have estimated out each of the different arrows and the strength of those arrows. Then if you do not have any bias, then your affirmative action metric would be that the difference of the prediction of one advantageous group versus the disadvantageous group should be the same, which means this metric should be very close to 0. So you can see that the affirmative action based, I'm just showing the random forest results. These are 0 means in actual data, I kind of use this to lower that bias and come up with this fairness. If I did not do this, you can see that if I use a plain vanilla random forest, I have my U and AA metric as defined over here is significantly different from 0. What does that mean? That there is a bias towards the advantageous group. So this is positive, right? This is negative. So there is a bias towards the disadvantageous group, means if I use a plain vanilla technique by these 2 metric, which kind of undertakes the causal graph approach, working behind it, is going to give me a prediction, and this is going to be the relative difference in terms of the number of, in this particular case, you are going to get at least 2 drugs per day or 3 drugs per day, more or less, depending on which group you are in, conditional on everything else, conditional on the structure of the underlying problem that you are going through. And here you can see that the results of that, if I have, for example, ethnicity, instead of insurance, if I use ethnicity or the distributions of, and this is private versus public, and this is white versus non-white. Those 2 distributions are very different from each other. And this is the kind of graph I gave you in the beginning, that one group is getting a higher treatment than the other group. But if I use the affirmative action, both of them are going to be very close to each other, and you can virtually see the difference because they're almost on top of each other after I have used the affirmative action-based fairness measure. I will stop here in the interest of time and to take some questions that we talked about algorithmic bias and fairness, and we talked about different problems, so many problems out there, a role of confounding and correlation, spurious correlation, training data problem. Causal graph is one way to address some of the problems, but it do have certain limitations, especially we need to know what the graph structure is, and at least that's where the domain knowledge potentially going to come from. But at least there we know what we are doing. And if we're making assumptions, we know what kind of assumptions we're making, and you can question about those explicitly versus doing anything ad hoc. I gave you some examples in terms of equal opportunity and affirmative actions. You can define other ways of fairness and work with this way. And I'm looking forward to your comments. Brittany, am I too late?
Yeah, no, I think that's great. Thank you so much for this talk. It was very, very informative. What questions does the group have? And feel free to raise your hand or drop them in the chat.
I had a question about if you're looking at different approaches to fairness, like whether to take out sensitive variables versus using the causal graph approach, like how do you go about choosing which approach you'll use?
So,
and thank you for the great talk.
Well, thank you. And that's Sally, right? Okay, very good.
Yes.
Yeah, thank you, Sally, for the question. So my first, and again, I didn't have time to talk about the entire part. As I mentioned that you would like to take out any racial feature because your causal structure has to have the racial feature in it. And I had actually other results which showed that if you had taken out the racial feature or any other sensitive feature, you might actually exacerbate the bias, depending on the way you actually define the bias. For example, the false positive rate goes up by using one AI algorithm which is unaware versus another algorithm which is aware of your sensitive feature. So in the causal graph structure, it is important that you keep that sensitive feature in the data, but you are aware that that sensitive feature is out there in the data so that you can actually estimate the structure out. And then you can debias accordingly. Does that answer your question?
Yes, thank you. Thank you.
Yes, Riddhi, I see your hand.
Hi, Sudip. Thank you. That's actually a really nice talk. And in our research group, we are also exploring similar problems like causal bias estimation and mitigation using these structural causal models on observational data sets. So I have basically 2 questions. The first one is when you're talking about affirmative actions and equalized opportunities. So what does it say in layman's term for this example? Like, what should be the action taken in order to mitigate these kinds of biases in simpler terms?
Right. So let me share the screen. I actually skipped that part in the interest of time. So so this is in this that I'm kind of going to ask what would have been the decision. So think about you made a decision based on this algorithm, and you know about my race, gender, whatever it is, that I am Sudip, and this particular person was diagnosed with this is the probability of me diagnosed with this. Now, when I'm doing the affirmative action, I'm going to ask this question that had I not been Sudip, had I been Riddhi or Sally, what would have been my probability of being detected under this particular algorithm? And here you can think about, I'm kind of switching my race or gender or any other way I'm going to be defined in this problem. And when I'm switching this, so this is my S to S prime. This is currently Sudip with this particular insurance provision or gender. And then this is Sally or Riddhi with a different insurance provision and gender. But we also know the moment we're switching the identity of the individuals, the other variables could potentially switch too. Because Sudip is a professor at Johns Hopkins University, comes from India originally and lives in East Coast and so many other observable factor you could find it. Sally could be coming from the West Coast, have a very different background. So any other observable factors that you already had used in the prediction, that should also change based on whatever the sensitive feature it is. Now, if I switch this, the two distributions should still remain the same. If that happens, then it is affirmative action. Does that make sense, or should I try a different way?
Yeah, that makes sense. So if I understand correctly, you are saying that it's not really possible to change the protected attributes of a person. So
Right.
when we have some kind of these differences in outcomes, we basically need to address the model and change accordingly so that the changes like
Right.
becomes close to zero, right?
That's right.
Okay.
And the way
I
I'm
have-
doing, I'm
yeah,
sorry,
sorry.
the way I'm doing these changes is I'm estimating the effect of my sensitive attributes on my other observed characteristics, right? And now if I change my sensitive attributes, how is the other observed characteristic going to change? Think about, I'm just simulating that information to generate a new causal graph. Not a new causal graph, but it's the same causal graph, but generate a new predictive outcome through that causal graph.
Okay, yeah, that makes sense. My second and the last question would be, so we are doing this kind of work, and the challenge that we are regularly facing is that when we're coming up with the causal models, so how do we really come up with a robust causal model that is backed by science and backed by all the prior information? So how do you tackle that?
So this is the challenge. As I said, this is one of the major challenge in the causal graph technique. And this is if the first thing comes, and I'll quote Daniel Pearl, is that this is where domain knowledge comes in. That how you choose what kind of causal graph comes in, right? This is where and this is again going back to the FDN SASMD things that we need interdisciplinary collaborations, because I may know a little bit about how to do these causal graph techniques. I have no idea how cancer detections or the clinical diagnosis of cancer should be undertaken. This is where I should be talking to, and that's the great thing. I actually have access in Hopkins or through this technique, and this is where we will be coming together to decide about what the underlying causal graph we think should be. It's a challenging problem. There is no easy solution to it, but I think this is a good way, at least, because we are bringing the domain knowledge, we are bringing in cross interdisciplinary and people who knows how these things to be done, as well as we are transparent about it. So that's crucial to me, that whatever graph we are doing, we're throwing it out there and say that, well, this is what we are forming based on these assumptions. We can change those. And then there are statistical ways of comparing that, well, if I had this graph versus this graph, well, some kind of error is minimized or maximized, some kind of a reward function, whichever way you want to define. But at least we'll know about that underlying structure.
Yeah, thank you so much for clarifying. An excellent talk. Thank you.
Are there any other questions? Okay, well, thank you again so much for attending today's talk, everyone. Thank you so much for the talk. I will be posting it in the next couple of weeks on our AI Ready blog, so please be on the lookout for that. And thank you again to our wonderful speaker.
Thank you, everybody. And I look forward, please, if you want to reach out to me, send me an email, and I look forward to collaborating. So If you have thoughts or work problem that you are working on, I'd look forward to know how I could learn from you as well as work on this together. Thank you.
Great. Thank you.